Hello, I'm Geehyun from Yonsei University, the first author of this paper. It's an honor and privilege to share this work. This study was conducted in collaboration with 11 major centers across Korea. Carcinoma in situ is a flat, high-grade, non-invasive urothelial lesion. Despite being non-invasive, approximately 54% of cases progress to muscle-invasive blood cancer if untreated. CIS at TRB is considered a high-risk feature, prompting PCH therapy and early radical cystectomy when disease persists or recurs. CIS at radical cystectomy has also been linked to urethral involvement, reduced pathological complete response, and worse cancer-specific survival. However, the prognostic significance of CIS remains inconstant across studies. Our objective was to evaluate the impact of CIS at TRB versus cystectomy on recurrence-free survival and cancer-specific survival. We conducted a retrospective multicenter study across 11 Korean urologic centers, including patients who underwent radical cystectomy between January 2010 and December 2019. After excluding patients with non-pure urothelial carcinoma, concurrent upper tract disease, and incomplete data, a final cohort of 2,553 patients was analyzed. Our primary endpoints were recurrence-free survival and cancer-specific survival, assessed using Kaplan-Meier analysis and multivariate Cox regression. The median age was 68 years. CIS was identified in 29% of TRB and 32% of cystectomy. 24% of patients received neoadjuvant chemotherapy and 53% had organ-confined disease. With a median follow of 36 months, recurrence occurred in 38% and cancer-specific mortality in 24% of patients. Patients with CIS at TRB demonstrated better survival outcomes. 5-year recurrence-free survival was 64% versus 53%, and 5-year cancer-specific survival was 75% versus 70%, both statistically significant. In contrast, CIS at cystectomy was not associated with survival differences. 5-year RFS was identical at 56% in both groups, and CSS was virtually the same, with no significant difference in either endpoint. In multivariate analysis, CIS at TRB was independently associated with better RFS. It was not independently associated with CSS. CIS at cystectomy showed no significant association with both survivals. The strongest predictors of poor survival were advanced stage, lymph node involvement, lymphovascular invasion, and positive surgical margins. Adjuvant therapy was associated with improved CSS. Our findings raise an important question. Why does CIS at cystectomy carry limited prognostic value? We believe CIS at cystectomy may represent a residual or previously treated lesion rather than actively progressive disease. Prior therapy, particularly neoadjuvant chemotherapy, may have attenuated its biological aggressiveness. In this context, CIS at cystectomy does not necessarily indicate active clinically significant disease. Regarding CIS-TRB, our results were somewhat counterintuitive. Patients with CIS showed paradoxically better RFS. This may be explained by baseline differences between groups. Patients with CIS at TRB had a higher proportion of organ-confined disease and more frequently received neoadjuvant chemotherapy. Additionally, guideline-driven management, including BCG therapy and early cystectomy in BCG-unresponsive cases, likely contributed to favorable outcomes. Taken together, the survival benefit in this group appears to be treatment and selection-driven rather than a direct reflection of CIS biology. Before our conclusion, I would like to acknowledge some limitations. This study has a retrospective design, and CIS diagnosis was based on each institution's pathological report without center review. There was inherent heterogeneity across 11 centers, and the median follow-up of 36 months may not be sufficient to capture long-term survival differences. In conclusion, CIS at TURB was independently associated with a lower risk of recurrence following radical cystectomy, while CIS at cystectomy had a limited impact on survival. These findings suggest that CIS at TURB or cystectomy carry fundamentally different prognostic implications, challenging the conventional risk stratification of CIS. We believe these results warrant re-evaluation in clinical decision-making. Thank you very much for your attention.